Good to go. All right. So real quick, before I get you a tree, in recognizes, so, you know, on paper it's always easy to be like, well, you know, explain P waves are going to be inverted with this, they're going to be, but actually recognizing stuff on an EKG, looking at an EKG and being able to say, well, that's AVNRT, or that's AVRT, or that's atrial tachycardia, or that's whatever, is more difficult, right? We'll go over that. There's all sorts of, you guys have all the practice strips, right? For testing, at least for Monday, know the, you know, the 5 criteria when you're looking at an EKG. What's the five criteria? So as you're going through, like all of the EKGs that we've been going through and all the slides that we've been going through, we describe what? So there's rate, there's, so yeah, you're identifying the PRI, right? You're looking at the P waves. So are the P waves present? Are the P waves absent? You're looking at the PRI. You're looking at the QRS, how long it is, and then you're interpreting based on that criteria. You're interpreting, right? So, like if a question comes up and says rate is 54, P waves present before every QRS, PRI is 0.12, QRS is 0.10. Your interpretation is what? Sinus bradycardia. Good. So know those criteria. All right, and that's how when you see an EKG, you start to write down that criteria, and then based on that criteria, you can start to make a decision on what it is. Okay, that's a good systematic approach in identifying an EKG, or at least the wave morphology. The difference between AVRT, AVNRT, when it's tachycardic, you can't tell the difference. Okay. So don't worry about that. I'm not going to give you a strip of a tachycardic and say, I want you to tell me if that's AVNRT or if that's AVRT. You can't tell the difference until you slow that down. For the most part, and for what you guys are learning, AVRT is going to be with WPW. If you can identify that it's WPW, it's AVRT. All right? If it's a re-entry tachycardia and there's no WPW, that's AVNRT. Does that make sense? So always associate the AVRT with WPW. AVNRT is without it. Because they're both going to have inverted P waves, right? And those P waves could be before, in, and after the QRS. Right?
Sure. Yeah.
All right.
So what are the 5 criteria?
Dilly dilly.
Rate, rhythm, PRI, QRS.
So it's rate, rhythm, P wave, PRI.
We have it on. I can go back to those slides. Am I missing one? P wave, PRI, QRS. And when you're identifying rhythm, what are you identifying? Like if it has rhythm, semicolon, what is it asking for? Yeah, regular, irregular. Regularly, irregular, you know, whatever.
You had mentioned about that tree thing you're going to make up. I'm guessing that won't be before Monday.
We'll see.
Yeah, no pressure. This place, they close the doors like you're going to run.
That's right. I'm out. We'll see. It certainly could be.
Be a great Christmas present.
All right. So we're going to be talking about junctional rhythms, and this one's This should be a lot quicker. We should be done within an hour. But you guys know about the AV node. Where is it?
In your heart.
And you can kind of see it's above the junction, right? It's in the atrium, right atrium. It delays the electrical impulse. Why does it delay the electrical impulse from the SA node? So you get an impulse. You get an impulse before there is a depolarization, right? As soon as that action potential is reached, there's an impulse. The impulse is just straight line, right? And then the depolarization is the waveform. So what is the ST segment? That straight line, what is the ST segment? That's the impulse for repolarization, all right? And then the actual T wave is repolarization. So the reason why the AV node delays the action potential or the conduction. So the SA node fires, sends the signal, atrium, there's an impulse, goes down, and then it's delayed at the AV node while the atrium contracts. So why does it delay it? If it didn't, you wouldn't fully fill the ventricles, right? You wouldn't get that atrial kick. It wouldn't have time. You wouldn't get the right filling. So it delays it so you can get proper filling of the ventricles. Good. All right, connects to the bundle branches. We know that. Hits pacemaker. I want you guys to know the pacing rate for the different aspects of the conduction system. All right, and just kind of memorize the conduction system on like a blank piece of paper. Practice drawing it out where, draw out the chambers of the heart where the conduction system is going down. That'll be important, I promise. Yeah, Gary likes you to draw diagrams. Diagram the conduction system.
So is the bundle of his connected right to the AV node?
Yeah.
Okay, and then
the bundle of His is what's actually going through the divide between the atria and the ventricles. All right. So the AV junction is where the bundle of His is, right? Bundle of His is that junction between the AV node and the bundle branches. All right. So AV junction resumes the automaticity when what? SA node fails. The SA node impulse is blocked. Then the AV node takes over. If the SA node is slower, then the AV node will take over. If the AV node is excited and for whatever reason it starts a rate higher than the SA node, it'll take over, right?
you said the SA node, if it drops below the rate that the AV node would be, then the AV node will just pick it up.
Yep. AV node will pick it up. So if the AV junction picks up the rate and the impulse comes from the AV node, what happens to your P wave? Inverted. So all junctional rhythms will have an inverted P wave. right? So if you're looking at an EKG and you think it's a junctional rhythm,
In lead 2.
better have an inverted P wave in lead 2. Yeah, all of these things are what we're talking about in lead 2. Do you guys, so, you know, I drew up this diagram, and we had a picture of it. You have it in your handout, the heart and where the leads are in the heart. That's kind of where the leads are placed on the body, right? Have you guys heard of, what is it, what's that guy's name? Eisenhower's triangle? Does that sound familiar? It's where it shows the either positive or negative impulses in a certain direction, and that which gives you a positive or negative deflection. Eindhoven. Is there a T in there? Yeah. Eindhoven's triangle. That's going to be important. I don't think we went over that very specifically in our lecture, but review that in the book. We went over the electrophysiology a little bit quicker, and we went over the. I didn't specifically go over the Eisenhoven, but know that triangle and what it represents. We talked about the concepts. So with any kind of AV junction, P wave, depending on how quick the conduction is, it can be before, during, or after. And you see kind of those examples. A is just normal with no junctional P wave, and then B, C, and D are those examples of the junctional rhythm and what happens to the P wave. So a PJC, we talked about PACs, we haven't talked about PVC yet, but PAC, premature atrial contraction, what's that? Okay, so there's a beat before the normal sinoatrial rhythm, right? Where does that come from? Comes from excited pacemaker cells, other than the SA node, right? That's why the P wave's different. Okay, so a premature junctional complex, where does that come from? It's junctional. The AV node? Yeah, so the SA node can be whipping out all these sinus complexes, and then all of a sudden there's a premature junctional complex. How can you tell the difference between a PAC and a PJC? PJC, because the P wave looks different than a normal P wave in both of them, right? But the P wave in a PAC is upright.
PJC should have a
PJC,
regular inverted P wave,
inverted P wave.
but always before the QRS, correct?
Yeah, for a PJC. Yep.
Why wouldn't it be during the QRS and PJC? Wouldn't it kind of, it almost seems to make sense that if you have electrical impulse going through the ventricles, that those contract before it goes through the muscles to contract the. Is it always occur before the ventricular contraction?
No, it's
For a for PJC.
Yeah.
before, during, before, after.
Yeah. Well, that's junctional beats can happen before, during, or after, but a PJC is before the complex. So the PJC, it arises from irritable site excited pacemaker cells, and it fires before the next expected beat. QRS is usually fine because there's still conduction down through the conduction system normally. And often there's that non-compensatory pause, right? Just like with the PAC. All right, so the PJC, I mean, it looks like, Trevor, your thinking is correct. It can proceed or follow the QRS, either. Is that an Air 5?
It's an Air 5. He doesn't want
I
me
don't
to.
have time for Air 5s.
So PJC, just like the PAC, it's not a full rhythm, right? It's just a single intermittent beat.
So it can happen before or after, but not during
For what the?
the PJC.
Yeah, it could still be during.
During.
Yeah. All right, recognizing it. What's your rate?
180.
All right, so your rhythm, can you tell that it's regular? I mean, at first glance, unless you really looked at it hard, it would just look irregular, right? If you think it's irregular, then you're looking at your P waves, right? And you can see that P wave morphology. From the very first complex, you've got that morphology, and then there's a quick beat that doesn't look like it has a P wave. Then you got that same morphology again.
Can you show us on the? Sorry.
So here you got that what looks like a fairly normal P wave morphology, right? And then you've got a quick beat with no discernible P wave. And then you've got another normal P wave, normal P wave.
That wouldn't have been an inverted P wave,
It could be,
but we're not just don't know.
but it looks like it's probably within the QRS complex. That might be inverted P wave mixed in with. It doesn't look like normally it has the Q wave. So yeah, you can call that an inverted P wave before. Then you got P wave, and then another one. P wave, another one. P wave, another one. So what would you call this? Trigeminy with PJCs, because you've got inverted P waves, right? What if you just don't see the P wave? If you just don't see the P wave in these intermittent premature contractions, how would you know what kind of contraction it is? If you don't see a P wave at all, it's got to be a PJC, right? Because a PAC, you're going to see a P wave.
Couldn't that be a PAC if it just depends where it's firing and sending that signal away from us?
What do you mean?
Well,
PAC is not going to be inverted, right?
if we see depolarization going away from our lead, we'd have an inverted P wave.
Why would you have depolarization going away from the lead in the
If
PAC?
we had an excited cell close to our AV node, and it's sending a depolarization back towards the SA node.
Put your little wire on that. It'll flatten, it'll get smaller, but it's not going to invert
Okay.
because it's still going towards the AV node, where the AV node is going out from the AV node.
What's the last arrow we talked about it going away, and therefore we'd have a inverted P.
with the PAC?
I thought so, but we can go on.
All right, check it out. You can come talk to me
Okay.
later. So you guys were able to identify all those PJCs, right? In that trigeminy type rhythm. So these are the rate rhythm, P waves, PR interval, QRS. That's your 5 criteria in interpreting an EKG. And then what's your interpretation? You've got all of that information. What's your interpretation? Okay. Sinus tachycardia in trigeminy with
It's not
PJC.
Isn't it not sinus because there's not a normal P wave?
Well, in your regular beats, you've got normal P waves.
Oh.
It's just that every third beat is a
Nice.
PJC, right? You've got premature complexes.
Or previous slides.
This one?
The rates, WNL.
Within normal limits.
Oh,
All right. What causes it? You guys know what causes all of this stuff. Most of the time they're asymptomatic until they become more frequent. Stimulants, we always talk about digitoxicity can stimulate these things. And of course, if you've got something that's causing it, don't take it anymore. Okay, junctional escape beats, different than a PJC. So they originate in the AV junction. They appear late. An escape beat is preventing cardiac standstill. So when do you think your heart is going to throw in an escape, a junctional escape beat? So when does the AV node take over? So sinus arrest. So if the sinoatrial node isn't throwing out a beat, and you've got this period of sinus arrest, sometimes the heart will, to prevent this pause of sinus arrest, will throw out an escape beat. The AV node will be like, oh wait, we need something there. This is too long. So a junctional escape beat will kind of be in what would be a sinus arrest. If it's long enough, the heart will throw in this junctional escape beat.
But that's the normal AV node picking in.
Yeah. But if the AV node is kicking in, it's going to have a junctional appearance, right? From a P wave perspective.
Right.
So you'll know if the AV node's kicking in or if the SA node is doing it.
Okay.
There's AV, there's a sinus arrest. There's not going to be any P wave.
There's not going to be a P wave?
Yeah.
It depends on why it's being arrested. You don't see a P wave here, at least. Not very well, because why? Where's your P wave? It's buried. Probably there. But the QRS still has injury. What's wrong with this patient? So that ST depression, there's ischemia. ST depression causes sinus arrest. The AV knows, wait a second, so this is a junctional escape beat in the middle of the sinus arrest. And then you can see a P wave that's kind of buried in there, inverted in an already ST depression state.
So because it's wider.
It's yep. All right. Let's see if there's anything there. 3 and AGF. Junction, so that was a junctional escape beat. That's going to happen during sinus arrest. If there's a pause, it'll throw in a beat. Junctional rhythm is, or an escape rhythm is basically a run of escape beats, right? So that's the AV node taking over. The rhythm is regular. The P waves can be before, during, or after the QRS. And they're inverted and leads to 3 and AVF.
Would that be ST elevation on that one as well?
Yep, there's definite ST elevation. And that's, I mean, these are settings where you're going to have junctional rhythms, junctional escape beats, because these are times when the AV node has to take over, because the SA node is being injured because of ischemia, right? So you'll often see ST abnormalities.
P wave was in front of the QRS in each of those junctional.
Inverted, yeah.
Is that correct?
What's that?
The P wave is in front of the QRS
Yeah.
in each of those?
Yep, exactly. Inverted in front of the QRS. All right. What's aberrancy again?
It's something that if we know, we'd really impress the doctor. And I can't even impress the present doctor.
One QRS, right?
Yep, it's a wide QRS with a supraventricular deficiency, right? So normally a wide QRS would be a problem with the ventricle, bundle branch block. Sometimes you can get aberrancy. There's a wide QRS. Good. What causes it is all the same again. Do you guys know what quinidine is? It's a TCA. So you guys know what TCA toxicity is, right? Quinidine's a TCA medication, or has TCA effects. So we know they can be asymptomatic or symptomatic, depending. Signs and symptoms are all going to be the same. Anytime you have a problem with the heart, same kind of symptoms, you know. If the symptoms are because of a slow heart, the AV junction's taking over, but it's not beating fast enough, you can give atropine, you can pace them, you can give dopamine, you can give epinephrine, any of the above. So an accelerated junctional rhythm, that's just when it's faster, right? So what's the normal automaticity of the AV junction? 40 to 60. So if it's going 60 to 100 and it's a junctional rhythm, then it's just an accelerated junctional rhythm. That's easy enough, right? So what's our rate? About 90. That works. Is it regular? Yep. P waves? Do you think there might be P waves present?
They're probably getting hard hit in the QRS.
Okay.
Is that why? Because of the increased rate?
If you have a regular rhythm and you can't discern any P waves, That's probably junctional. The P waves are being hidden.
So the P wave is the atria firing, right?
Mm-hmm.
So if the atria is firing during the QRS, and the ventricle's firing, wouldn't you have to worry about blood backing up and going out?
It's separate from the actual pump.
So it's all a pressure gradient, right? So the valves don't open and close based on what the atria and the ventricles are doing. It's all a pressure gradient, right? So if the ventricle starts squeezing during the contraction of the atrium, most of the blood's already gone into the ventricle, right? The rest of it just goes in with the kick. So if the ventricle starts contracting while the kick's happening, what happens to the valve? Snap shut. It's pressure gradient, so you don't get that backflow. It's just that you don't get the forward flow. Ventricle's a lot stronger than the atrium contracting. Does that make sense?
So is that going to result in a lower blood pressure then? So then you'd be getting less filling.
You're getting less kick, less filling you would expect the blood pressure, the overall cardiac output is going to be lower. Now, whether or not the body can compensate for that, I mean, a young, healthy person, what is the body going to do to compensate for lower cardiac output? To try to, this is important. Remember this, write it down. How do you calculate blood pressure? That's cardiac output. How do you calculate cardiac output?
Volume times rate.
Stroke volume times heart rate. How do you calculate blood pressure? Cardiac output times peripheral vascular resistance. So that's what your blood pressure is, right? The amount of blood flow going through times however that vessel is composed. If it's constricted, dilated, if it has a disease, that all makes up the resistance, right? And that's what blood pressure is. If you don't have any resistance, your blood pressure goes. If you don't have any cardiac output, your blood pressure goes, right? So remember that calculation.
Cardiac output times.
Cardiac output times peripheral vascular resistance equals your blood pressure.
Junctional rhythm. What's wrong with that? Seems like it's fairly decent.
Accelerated junctional rhythm, yeah, it could be asymptomatic. It just means that your AV node is taken over from your SA node. If it happens suddenly, that means something happened to the SA node, right?
Okay.
But if you're looking at this, do you see any signs of ischemia? I don't. So why the SA node gave out, I don't know. Do an echo. But it certainly requires more treatment. But it might be just completely asymptomatic. Patient might not even know. Feel a little fluttering, but other than that, nothing. So you know that that's a junctional rhythm because there's no P wave and it's regular. And because the heart rate is above 60 and below 100, it's accelerated junctional rhythm, right? My voice is giving out. So causes, all the same stuff, right? Causes are everything causes all of this stuff. So you quote me on that. Everything causes all this stuff. That's a terrible.
Is that going to be the answer on the test?
No.
Everything causes all this stuff.
You can just, if you write that down, everything causes all this stuff.
Just put that by name and it in.
The causes are all the same for all of these dysarrhythmias. How about that?
Yeah.
All of
There
these
is no distinction.
all of these bad diseases can cause different deficiencies and dysarrhythmias on your heart. But it's good to know a few of these causes. You know, the big ones. MI,
Ditch.
surgery, COPD.
Yeah, I don't think I'll ever take that.
Yeah,
Every one of these.
Digitox causes everything, right?
It's on every one of them.
It's Digitox sucks to treat.
So is it safe to say that it's just basically the severity of those that causes the?
Yeah, so any of these, anything that causes excess strain on the heart. COPD causes excess strain on the heart, right? Because it's pumping against that disease. Pretty much most lung disease will cause strain on the heart if it's chronic lung disease. Surgery doesn't have the doesn't have the feedback from the body as well anymore. So that can cause these different rhythms. Of course, MI is going to cause a problem on the heart. Hypokalemia. What are the 4 major electrolytes? We're talking about hypokalemia. What are the 4 major electrolytes? Sodium, potassium, calcium, magnesium. What always follows sodium? Chloride. Magnesium could be a 5th, but when they're asking test questions and in your book, they're always going to say, what are the major 4, right? What are the major 4 electrolytes? Sodium, potassium, chloride, calcium.
What does chloride do?
Chloride balances sodium. Binds sodium.
Sodium makes food taste good.
But there are chloride pumps. Anytime you have a sodium potassium pump, there's going to be chloride pumps that also go with it. It's all the balance of ions. I'm kind of getting on all these random things just because, guess what? I just reviewed your test. During depolarization, where is sodium and potassium in relation to the cells?
In polarization, potassium's going out and sodium's coming in.
Okay, good. During depolarization, sodium's coming in, potassium's going out. During repolarization, or I should say at the end of diastole. End of diastole, where are the ions?
Sodium's outside, potassium's inside.
Sodium's outside, potassium's inside. Good. Where's your calcium?
It's ground up with a certain molecule. So
It's inside the cell, ready to go to the muscle.
is that why hyperK is such an issue? Is because because all this hyperK is outside the cell and it messes up that gradient?
Yeah. Because it makes the cell think that you're in a constant depolarized state, and then you can't repolarize, right?
And it won't. Okay.
All right. I love this. Every slide. Maybe asymptomatic. If they have Digitox, don't give it to them anymore. Oh, the slides are funny. I apologize for these slides, and I guess this morning's slides, because my thumb drive was here and not at home, so I couldn't review them as well. So I did the same thing you guys did. I went through the chapter. All right, non-paroxysmal junctional tachycardia. So if it's non-paroxysmal, it's fast, right? It's constant, I should say. So accelerated junctional tachycardia, all right, accelerated junctional rhythm is what? Heart rate. 60 to 100. A junctional rhythm is what? 40 to 60. So junctional rhythm, 40 to 60. Accelerated junctional rhythm, 60 to 100. Junctional tachycardia, over 100. If it's non-paroxysmal, it's consistent. You don't even need to say, I don't even know why you need to say that non-paroxysmal You just say junctional tachycardia. If it's intermittent, then it's paroxysmal junctional tachycardia, right? Starts and ends. And just like atrial tachycardia and PACs, junctional tachycardia usually is stimulated by PJCs. All right. Rate rhythm, P waves. Rate is fast, right? What's it at? All right. That sounds about right, 140. Rhythm, regular. P waves,
Not present.
what do you think? Not present? Might be buried in that ST segment,
Yeah.
right?
Could they be inverted, or is that the Q wave itself?
Junctional P waves are always inverted, right?
Well, I mean, what I'm looking at there, like, let's say on the fourth
Which
beat.
one? Before the QRS?
Yeah, that fourth beat there, is that an inverted Q wave, or is that?
That's Q wave.
Q wave, okay.
Yeah, that's a Q wave. This could be your inverted P wave. Because that's not a normal ST segment depression, right? You can see that S wave is already starting to go up, and then there's probably that inverted P wave right there. So that's junctional tachycardia. And then it's just talking about the PR intervals. So if you get this strip, and I'm not saying you're going to get this strip, but if you got this strip, you go through your 5 criteria, what would you put as the PR interval? Yeah, none. There's no PR interval, right? And then what would you put as the P wave? And this gives you a whole bunch of different options, but if you were to describe this strip, what would you put as the P wave? Okay. Inverted, possibly buried in the QRS. Or probably buried in the QRS.
So you don't, it's not the image in the ST segment, that little conversion? Isn't that-
Well, I guess that's what I mean. Yeah, I think that's in the, I think that it's in the ST segment.
So is reading an ECG just, even if you're wrong, just be confident in it? And people are like, yeah.
That's what makes doctors.
Yeah, people will probably believe, yeah.
Because I hear you saying, well, I think so. So I'm just thinking, even if I'm wrong, I'm just going to be adamant that I know what I'm talking about.
Yeah.
Okay.
All right. Well, let me phrase that different. The inverted P wave is in the ST segment on this rhythm strip.
I think you're right. I would concur. I concur. But thank you for asking my opinion.
You guys will never see theophylline administration anymore. That's an old medication. So you don't need to worry about that as a cause.
Yeah. I think I can remember that. Did you tell us about clue what it means? It's not a-
So if you have a patient with a heart attack and it takes out the SA node, the JV or the AV node takes over, causes a junctional rhythm. And because the heart attack messed up your pump, your blood pressure is low, then what is your AV node trying to do? Speed up, try to improve your cardiac output to recover your blood pressure. And that tachycardia is going to do what to your heart attack? Yep, it'll increase your ischemia. Good. In a patient, obviously, that increased ischemia is going to cause increased pain. The infarct will be worse. and then further go down the cycle of worsening ischemia, worsening blood pressure, and cardiogenic shock. All right. So if symptomatic, depending on how they look, the standard therapy, give them oxygen, IV access, you can give them some fluids, try some vagal maneuvers. If it's significantly tachycardic, you can certainly try some adenosine, or you can try to slow it down, and that's it. Junctional rhythms are not too bad, right? In comparison to
It's a little more straightforward.
supraventricular
So
rhythms.
I was wondering, on the junctional rhythm with the first key waves, because it was supposed to be a pulse. I can tell the difference between that and a re-entry pulse.
Tell the difference between a junctional rhythm.
Not a rhythm, just whether it's junction. I mean, I imagine if you look at it, probably now, but when you look at just the junctional versus a re-entry, where they both can have deflected P waves, is there something about a re-entry rhythm or just the way that it presents? It's going to be obvious, but you're like, no, this is a junction.
So a re-entry. So we'd be talking about, and we're not talking about PJCs. You're talking about like a junctional rhythm versus
Or even just
re-entry
PJC.
tachycardia.
I mean, just anything that would look similar, because I mean, in one, we still have an atria that's working, it's just not working correctly,
Mhm.
and we're having the entry. And another one where it's no PJCs, but PSA just decided for whatever reason it wasn't going to do its job for itself.
And you're wanting to know how you can tell the difference on the morphology. So what happens to the QRS in both of them? The re-entry changes the P wave as it goes back up,
Right.
but you still have a conduction.
Okay. So would it be that the QRS, because it's already happening, but there's a re-entry happening, they have different, and that would have different size, different types of.
Well, the QRS should be actually normal in both of them, because your conduction down through should still be okay. With a re-entry pathway, it depends. So a junctional will look very similar to an AV NRT, where it's
Right.
nodal, right? Because it's through the AV node. If it's not nodal, it's the QRS is going to look a little bit different. If you have an accessory pathway that's not going through the conduction system, that's going to delay your QRS impulse, right?
Right.
So you'd have a wider complex.
Okay. And would a rhythm with PJCs or even a junctional rhythm, would that present as more regular?
Yeah, a junctional rhythm is usually always regular.
Okay. I was just wondering about regular. People have different people, so.
Right.
Okay.
You guys want to go over some practice strips?